Hello and welcome. I'm Beth Claxton. I'm a medical doctor, board certified in obstetrics and gynecology and certified in functional medicine through the Institute for Functional Medicine. And today we have with us Carol Petersen. Carol is an accomplished compounding pharmacist with decades of experience helping patients improve their quality of life through bioidentical hormone replacement therapy. She graduated from the University of Wisconsin School of Pharmacy and is a certified nutritional practitioner. Her passion to optimize health and commitment to compounding is evident in her involvement with organizations, including the International College of Integrated Medicine and the American College of Apothecaries, the Academy of Anti-Aging Medicine, A4M, American Pharmacists Association, and the Alliance for Pharmacy Compounding. She was also the founder of the first chair of the Compounding Special Interest Group with the American Pharmacists Association. She chairs the Integrated Medicine Consortium, an umbrella group for complementary medicine organizations, and she co-hosts a radio program, Take Charge of Your Health, in the greater New York area. She's on the medical advisory board for the Center for Menstrual Cycle and Ovulation Research and the Institute for Bioidentical Medicine. She also writes and edits for A4M's website and is a co-producer of Immortality News podcast. She offers personal consultations at www.thewellnessbydesignproject.com. Welcome, Carol.
Oh, thank you, Dr. Beth. It's my pleasure.
Oh, it's great to have you. So one thing that you've taught me and that I've learned over the past few months is a phenomenon called estrogen kickback that you say is what they talk about online on the Facebook and Instagram. And I think it's a pretty appropriate name for what it is. So as I understand it, when women are starting to take hormone replacement therapy, probably if they've been off of it, like if they're not exactly transitioning from having menstrual periods and immediately starting hormone replacement, a time when their receptors may have gone dormant. We start estrogen and progesterone and sometimes testosterone at the same time. And there are many providers, myself included until recently, who would start progesterone at a lower dose. And what I've learned from you is that the progesterone actually helps upregulate or regenerate those estrogen receptors so that women have more symptoms of having estrogen deprivation. So even though they've started hormone replacement therapy, everything seems worse. Yes?
Yes, yes.
Okay, good. So can you talk a little bit more about this and maybe even examples of patients that you've treated so that women can understand this a little bit better?
Okay, a part of what I learned early on in my career was actually working for Women's International Pharmacy for 27 years. And we started doing a compounded progesterone in oil capsule. And this was all based on the work with Katarina Dalton. She's the doctor who wrote and researched PMS. She gave the syndrome the name. She also characterized all these symptoms of progesterone deficiency and gave progesterone and had some very good results. And her starting dose, first she had used injectable, which we know would be 100% usable. Everything goes in, but progesterone injections are very painful. So she switched to vaginal suppositories, and the dosage was like 400 to 600 milligrams in those suppositories. And you might have to repeat the dosing to satisfy the body's need for progesterone. And an interesting thing she writes about, progesterone levels weren't necessarily coming up low on the serum testing. Mm-hmm. So she theorized that something else was going on, and maybe at the progesterone receptor could be impeded, and that's probably true in part. So with the oral capsules, and this was work published by Dr. Joel Hargrove and Wayne Maxson on using a capsule with micronized progesterone, very small particle size, delivered in oil. The hormones that are all made from cholesterol are fat-like. They're not specifically fats, but they resemble fats in a lot of ways. And this dosage form was hoped to be the answer to the suppository thing, maybe more convenience and easier to use. The starting dose we worked with was 100 milligrams 4 times a day, but it's apparent that it didn't work so well for every woman. And the doctors we were working with, also having been schooled in the Katarina Dalton philosophy, would go up. They might prescribe some other things. We got compounding many other things, rectal solutions, vaginal suppositories, lozenges, creams, gels, all sorts of things to try to get the progesterone up. For example, if they would have some breakthrough, some doctors would prescribe a lozenge of progesterone to get them over the hump. And this was resolved actually very quickly. The moody things of PMS, the high anxiety, panic, even suicidal tendencies and severe headaches, you can get to a dose very quickly where that's resolved, 100%. So in my time at the earlier days, we recognized this and we called it breakthrough, actually, when the progesterone wasn't enough to take care of all the symptoms. So fast forward, I was with Women's International for 27 years. And then I was not, COVID started. And so I decided to look to Facebook, and I was looking for the failures. And I was missing the interaction with people who were trying to help themselves and doctors who were trying to help patients with hormone problems. And it's really eye-opening. More practitioners maybe should hunt up their specialty and see if there's a Facebook page and see how people are faring, because a lot of times your patient just disappears. They don't tell you they have a problem. They just say, well, this doctor's not got the answer for me. I've got to keep looking. And 40 doctors later, and they're still dissatisfied, and they're talking with their peers. Well, one Facebook group, it's called the Estrogen Dominance Support Group. Estrogen dominance was a term that was coined by Dr. John Lee. Dr. Lee wrote a very, very good book on the nature of progesterone. He called it Multiple Roles of a Remarkable Hormone, progesterone, and he was totally right with that. But he was wrong, in my opinion, with some other things, because he became entrenched in this notion that 20 milligrams of progesterone is all that you need. That's what the ovary produces. And so you shouldn't really need any more. He was not taking into account that progesterone is actually made by the adrenal glands, all the nerve cells in the body, all the mast cells independently in the brain. We make progesterone everywhere. And we sort of made sort of a transition. Maybe we didn't know all that at first. We thought organ makes the hormones and it gets in the bloodstream and goes all over, instead of all this hormone creation all over the place. In the 30 years of research makes a big difference. So hindsight. He also embraced saliva testing as a way to monitor your hormones. Well, I don't mind saliva testing. Under certain circumstances, you have to know the limitations. And I found a great deal of good basic science on saliva testing in forensic medicine. Strangely enough, makes me wonder why they're measuring hormones for autopsies and stuff like that. But they were, and they were published. And so I learned about some of the limitations of the testing. For example, until recently, all the saliva testing was done with radioimmune assay or immunoassays testing, which is not 100% hormone specific. You get spillover into other hormone identities. And so it's got a big negative in its lack of specificity. And then for some strange reason, when you treat somebody, particularly with topical hormones, not so much with vaginal or oral, zip, the saliva goes up.
Yeah.
And all these years later, we really don't have an adequate explanation for why that is, except I heard one doctor say, what we know about saliva testing when you're using hormones is the hormones go up in the saliva. We don't know. What we make this assumption for every test that we try to do. We're trying to correlate that this test somehow reflects your whole body. But we already know that hormones are very specific in where they go and how they go. For example, for estrogen, we have lots of receptors in our breasts and our uterus, and less receptors in our muscles. So what are we measuring when we have an estrogen number? We're whether you do serum, saliva, urine, it's still, we're trying to assume here that the number we get reflects our whole body. And it's not true. You have to, in my opinion, go by the symptoms.
Yes.
So one of the things, Dr. Lee eventually had his own progesterone cream, but he promoted the use of one called Progest.
Mm-hmm.
And each dose it had 16 milligrams of progesterone. And Julian Whitaker had a newsletter, and he put our pharmacy in there as a source for Progest and for bioidentical hormone compounding. But we didn't have Progest. We were just busy compounding for the severe PMSers. But so we had so many calls, we stocked Progest, and we soon had many women calling us back and saying, I'm having trouble with this, I'm worse with this Progest cream. And we fortunately had the background to know what was wrong. We called it breakthrough. The estrogen dominance Facebook group calls it estrogen kickback, which I think is good a word as any. I'm sure it's not going to be recognized medically, but I can give you some terms if you want to use it. How about the biphasic nature of progesterone? How about progesterone inversion? We have some drugs actually behave like that. Some doses produce one activity, other doses produce another activity. We know that for a few other things. So it shouldn't be that hard to agree to accept that for progesterone. So we also had, I personally had a young woman call from across the country, and she was suicidal. Her nurse practitioner had given her, I think, 100 milligram progesterone capsules. And I said, please take one every 15, 20 minutes, and let's talk in an hour.
Okay.
And so she and I reconnected, and she said she was feeling very much better. And she said, it just proves I've been trying to tell my doctor this is all hormones, and she wants to put me on antipsychotic drugs. And here it is, this progesterone made a big difference. I even got a call from her practitioner, very annoyed with me for giving her different instructions. I go, did you rather she killed herself? I don't understand, but
What dose did she end up settling into?
So I don't know what dose she settled into, but it probably took her probably 3 or 4 doses within that hour to get to where she felt calm and relaxed and not panicking.
Yeah.
And
so 100 or 400 milligrams a day might be a really nice dose for people.
Right. And so it is. Kind of an interesting study I saw along those lines, and this was in menopause treatment, was they were cycling menopausal women. They were on some dose of estradiol, and they would do, I don't know if it's 10 days or 14 days, but they did 100 milligram daily, 200 milligram daily, and 400. And the 100 milligram daily never bled. The 200 sometimes bled, and the 400 bled regularly. You needed enough progesterone to get that secretory nature of progesterone to get rid of that endometrium.
Yeah.
So back to the estrogen kickback. I'm not sure it's all estrogen because I'm having to rethink this a little bit, because there's this issue with adrenaline. And social media thinks cortisol is a big danger, and maybe you don't want to take progesterone because it's going to raise your cortisol. But thank God you have some progesterone as a reservoir for cortisol, because you're actually dealing with a stress. You shouldn't be withholding progesterone because it's going to make cortisol. If you're making cortisol, you need it. But we're not sorting out very well the adrenal hormones and how it's adrenaline that whips right up. And the cause, I think it's probably more than estrogen, responsible for the sense of panic, your heart beating out of your chest, and women run to the emergency room. Maybe they'll get a benzodiazepine drug to calm them down, and they do all these cardiac tests, and nothing's wrong with them. There's nothing, nothing going on. And the amount of panic and terror women can experience in these circumstances is significant, and not all that unusual. It comes up a lot. So
you think that has to do with the progesterone feeding the cortisol production and their need for that to play out what their body is processing?
Progesterone needs to help the cortisol, but according to Dr. Michael Platt, who wrote a book on adrenaline, if your blood glucose drops, your adrenaline surges. And I believe that's probably the biggest factor in those heart palpitations, high anxiety, a drop in blood glucose. And what I'm seeing with coaching people and looking at their labs is we have an epidemic of insulin resistance going on, just huge. One of my colleagues told me she had a client who was wearing a glucose monitor. When she would have a hot flash or night sweat, her glucose went down to 50. I just talked to a client of mine who had been wearing one, and she said, I can verify that. She said, my glucose would go down to 40. It's a huge drop. So one of the functions of adrenaline is to keep your blood glucose up so your brain has enough glucose to function with. We have another impediment with this high adrenaline. Is the primary detox pathway for adrenaline is methylation. And a good proportion of us don't methylate very well. So I know I'm finding that a lot of women already know this. They're doing a SNPs, or they're testing for homocysteine and told they were not methylating very well. And if that's the case, they're not going to detoxify adrenaline very well. So it's going to persist. You actually have women in this state of high anxiety for hours, days, all the time, because they're unable to lower that adrenaline. So progesterone in part will balance it. Eating will balance that. And of course, methylation to get a detox would be how you need to handle that. So I think the estrogen kickback, yes, is valid, because you see stuff otherwise, like you see your breasts blow up and become very tender, or you get headaches, like you never had a headache before, and you use a little bitty amount of progesterone and you get a massive headache. And these women, not being forewarned, are going to think that they're allergic to progesterone, or progesterone is evil. It's the worst thing they have ever done. And their doctors are equally ignorant, because they'll say, oh, well, half the dose.
When really they need more.
Yeah, when they need
Right.
more and lots more. And so when I speak about that and then I run into women like that, they're like incredulous. I had such a bad experience. You have no idea. I said, yes, I do have an idea.
Mhm.
And you actually went in exactly the wrong direction. And it can take a woman weeks to recover from a tiny dose of progesterone. I'll even say don't take progesterone at all if you're going to take a tiny dose. Don't, it's too dangerous.
Mhm.
I wondered about the long-term consequences of this. John Lee lectured. I had a tape of his lecture. He was speaking in New Orleans, and he goes, well, yes, progest can cause these things to happen. Just keep using it, and in 9 months, you'll be fine. Ah.
Yeah, what about taking 4 doses?
Oh,
Right.
right, right. When I
Feeling
know you can do
better.
this right away.
Yeah. Yeah.
And who would put up with that? Women don't put up with that, but
Yeah.
they become convinced that the very thing that they need is somehow harmful for them. And it is if they continue those small doses. I think it's dangerous. If you're on a dose of progesterone that hasn't gotten you completely calm and improved your sleep and keep your breasts from being fibrotic and sore and enlarged and no headaches and no water retention, no weight gain. Another thing that's going on with this insulin resistance and this estrogen dominance picture, women are gaining weight left, right, and center.
Right.
And they feel pretty helpless about that because fasting will not help. It'll make it worse. Lowering your caloric intake will make it worse because then you are pushing your adrenal hormones to try and keep up the glucose. And of course, cortisol goes with that, and you're going to be retaining fluid and storing fat. So it's sort of a nightmare when you're going in the wrong direction.
Mhm.
And some of the things I've been talking about, for some women, they're aging kind of gently. A little bit of progesterone might be all they need. But there are many, many women out there who have so many things to try to handle, and they feel helpless. The one thing I've noticed, and I really like it, I try to teach people I coach, that once they get to the point where they can feel how progesterone works for them, they will, they're in charge now.
Yeah.
They know to take more if they're feeling stressed. They can experiment with using a little less if everything's going well. Progesterone is probably the most volatile hormone that you need to really pay attention to. And I believe it's because it has so many functions that it needs to be generous in order to cover pervasively all this work. So the things like anxiety is brain related in the GABA receptors. What's really beautiful is even though the brain can make it by itself, exogenous progesterone will help. The same with the Schwann cells, which are in all our nervous system tissue. It makes its own progesterone and pregnenolone and used right there. Talking about tests, this doesn't show up on any tests yet. You use some progesterone and it will alleviate aches and pains, and that can be pretty quick too. I was at a conference and one of the lecturers later in the day told me he thought he'd fall over while he was lecturing because he couldn't feel his feet. So I gave him progesterone to rub on his feet. And he comes back the next morning and he goes, "What have you done to me?" It sort of scared me. And he's dancing around. He said, "I feel my feet." So he had neuropathy in part because deficits for those anti-inflammatory hormones, pregnenolone, progesterone, hydrocortisone probably. And it makes a huge difference, and it's quick, which is also like the estrogen kickback thing that you can resolve it quickly.
Yeah, what a great story. So I have a question. How long should women be patient with these crazy fluctuations in symptoms? to let their new bioidentical hormone replacement therapy settle in?
Well, I'm convinced nobody should start it without starting with progesterone and getting a handle on how that can be volatile, how they can need more or need less, according to the circumstance, according to what you eat. You have a glass of wine, for instance, zip goes your estradiol. That's been published, like way up. So you have a glass of wine and all of a sudden you've got this kickback thing happening. If you realize you're going to be creating more estrogen with that glass of wine and quickly take more progesterone, you like neutralize that effect. So you have to have the information and the ability to understand how that works in your body. So then progesterone is the first hormone to drop in the perimenopausal time. It's actually the first one to cause be involved with that vasomotor thing. Remember, I said it helps balance that adrenaline from the blood glucose drops. Right. So in our medical conventional thinking, it's estrogen, which I can't understand because estrogen, if we use just estradiol, you can make that worse. But this vasomotor stuff was first approved by the FDA for Premarin. And the tricky thing about Premarin is it's not just estrogen. I have a paper with 60 steroidal molecules identified from Premarin. And some of these are estrogenic, some are more progesterone-like, some are more androgen-like. So yes, Premarin can have an effect that estradiol doesn't, but in our social consciousness, oh, you need estrogen to treat vasomotor symptoms. No, progesterone will do it. It will help you with that, but I would also send you back to look at your blood tests for insulin resistance, your fasting glucose, fasting insulin, hemoglobin A1C, maybe triglycerides, uric acid.
Yeah.
And get some idea of, is your diet contributing to these blood sugar swings? And I would propose too, there's another little piece in here to stick in. So it's like the universe speaking to me. I thought 6 clients in a row had low cholesterol levels, not treated with statins. It ranged from 86 to 132. I'm talking about exceptionally low. So these people, one was a man and 5 were women, could not really be expected to make hormones adequately to help themselves. They're going to need hormone support to recover, and they really need to change what they're eating. One of the women, she's been very brittle. She takes 2,800 milligrams of progesterone on her skin every day. If she doesn't, she gets into a panic and anxiety, just like that. But what was she eating when we first started talking? Her protein was pea protein in a smoothie. I'm very suspicious of smoothies, and an energy bar with nuts and seeds. So she was getting like no fat, very little protein. And women need protein. We need, and especially older women and men, our protein needs are higher than when we were younger, actually. And it's coming a time where we're eating less and less protein, less fat, where we're told to avoid that. And the very thing you need, we're being told to avoid.
Yeah. I agree with that because I've experienced it myself. Yeah, some protein, makes everything seem like a lot more level.
Right, it's easier. Talking about getting insulin glucose to even out.
Right.
Protein and fat really helps keep that level, so you're not having those rapid swings and surges of adrenaline that you can't get rid of, and you're a mess. It's really essential to be mindful of that. Katerina Dalton's solution back when was she had women eat 5 times a day complex carbohydrates, which I'm sure was helpful. But I think protein and fat added to the diet has an even more stabilizing effect.
You know, I've recently discovered I generally in the summer have a salad with some kind of fish, like canned salmon, tuna, sardines on it for lunch. If I add a quarter to a half an avocado to that salad, I'm good until dinner. And if I don't, I get munchies around 3.
Yeah,
It's that easy.
it's right. It's that dazzling, and it requires that you pay attention to your body.
Mhm.
And that's a big problem. We've been conditioned to give our health information or our health knowledge away, that we depend on other people to tell us what to do, where we really need to listen to our body and do these N of 1 experiments where we're the guinea pig in our own life, and you need to make adjustments and realize what is doing what for you. Of
Right.
course, kickback, if you have a kickback, you know, that's that's a negative experience, and well, something to be noted, but you have to have the information that more is better.
Yes, that's good information to have. And yeah, I want to encourage women to use their intuition
Yes.
and really go with that and listen and offer that up as a potential solution. Because when women come to my practice and say, you know, I think this is what's going on, I usually can't agree more. You're exactly right. Even if it sounds crazy.
Somebody said, if you listen to your patients, they'll tell you what's wrong. If you listen further, they'll tell you what to do.
I have to agree. Yeah.
And I think that's absolutely wonderful. But and sometimes I can feel that it is actually going along in a negative sense, but that's what they're feeling at this point in time. There's really nothing you can do about it. If they're in a paradigm where they believe this is it, for instance, which I disagree with this, one of my clients strongly followed a guy, I forgot the name. He was promoting that you absolutely should avoid vitamin D.
Hmm.
And she was a mess. She was autoimmune stuff. And that's another little piece. If you're working with sex hormones, adrenal hormones, vitamin D needs to be there too. And so she wouldn't entertain using vitamin D at all. And so how do you get away from that? So you have to almost wait till the person wakes up to, well, I've been doing this and it's not really working for me. So do I need to look at something else? And people do come to that realization, and they're ready to change. And sometimes it's not because of you. It might be 10 people were needed to bring that message that well, you could try this other way. And maybe by the 10th one, they go, oh, maybe I'll try this. And of course, it's the original idea. And
Exactly. I needed to hear it from the right person.
right.
Yeah.
So I don't get discouraged if somebody doesn't hear it the first time. If they and I say, if what I say to you does not resonate with you, it's not for you. Go check out something else. But if it does resonate, you know, this is how I can help you.
That's beautiful. Yeah. That gives them the choice and the power.
Yeah.
Which is taken away from so many women. And so many, all of us actually in Western medicine.
Oh, it's horrible.
Mhm.
Then can I bring up the case of the PMDDers?
Yes, and then we'll wrap.
Okay. So in the late 90s, Prozac was running out of its patent protection.
Mhm.
So they were looking for a new indication for their drug, their SSRI.
I remember this.
Yes, and so they actually did do a study with women and they created the PMDD, premenstrual dysphoric disorder. What they sort of did was slice off the emotional pieces off the PMS list of symptoms and put it into its own little category. And their study that they published said that was something like 50% effective for some of the symptoms. Well, that became very much entrenched. It became, I thought at the time, I go, well, this is nonsense. Progesterone works. Why would everybody be turning to Prozac instead? But how wrong I was until I was on some Facebook pages and talking about extra progesterone. And a woman from Great Britain got in touch with me, and she has a PMDD Facebook page. And she said, we've been listening to what you've been talking about and writing about using lots of progesterone. The PMDDers are routinely taught that they have to avoid progesterone at all costs. And some of them have this experience with, again, estrogen kickback, not enough progesterone. So they know it's true. Yeah. So she and a couple of her friends bravely took extra progesterone. I'm not sure what doses they all used, but she said it was nothing short of transformational. And so there's a couple women out in Great Britain that have these PMDD pages, and they are training women to go for it and use the extra progesterone. I think there's a progesterone conspiracy. If you are a family doctor in the UK, which is your first entry into their medical system, you're only allowed to prescribe 200 milligrams of progesterone. That's it. So these PMDDers are seriously low in progesterone. They've been low for a long time, a long time. And so they need especially generous progesterone. So they are like going to other countries. They're getting over-the-counter creams from the US. It's a big hurdle, but they're making it, and they're teaching others. So it's an inspiration to me. And what a conspiracy it is that this is the progression. If you get labeled as a PMDDer, that means you've got this emotional part of PMS.
Right.
You're offered Prozac or another SSRI, you're offered birth control pills. That doesn't work. You're offered a drug like Lupron, which strips you of hormones, and you're given estrogen back. And guess what? Now your estrogen is
again
way up there, and you're miserable. And then when all that doesn't work, of course, you have to have all your organs removed. And of course, they're given estrogen only, and everything persists. It's a racket, and it's criminal. In my estimation, the very thing they need from the get-go is progesterone, and they'd be fine.
Yes, I agree with you with what I've learned. Yep, absolutely. People love it, and it does so many good things. And I had someone yesterday say, I wasn't believing that this was happening so quickly, that this was helping me so much. Like, she didn't want to believe it. She said, I'm a scientist, and it just was way too fast, faster than I thought it should. And everything resolved so quickly. But in the end, she had her symptoms resolved.
I know you can't deny it. Sometimes I've seen women who haven't slept well in years.
Right.
The progesterone, they have the first good night's sleep that they've had in 7-8 years. What do you say to that?
Like, it makes tears come to my eyes, honestly.
Yeah, me too.
Yeah, it's so beautiful. Well, thank you so much for your time. I think we talked about a lot more than just estrogen kickback.
There's my buzz.
Okay.
Hold on.